Aloha, I am Mark Alexander, Executive Director of the Hawaii Medical Association. Thank you for joining us for today's special presentation with Professor David Rosenbloom, who will speak on healthcare perspectives, prior authorization, the who, what, where, when, why of prior authorization. The partners for this special event are Aloha Care, the Hawaii Provider Shortage Task Force, the Hawaii Pacific Basin Area Health Education Center, the University of Hawaii John A. Burns School of Medicine, and the Hawaii Medical Association. The format for today's presentation will be as follows. We'll start with a 40-minute presentation by Professor Rosenbloom. After that presentation, we'll move to a question and answer part of our program. Dr. Kelly Withy of AHAC and Jabson will moderate the discussion. Those in the room will be invited to ask questions directly to our presenter so that we have some active engagement here on site. Those participating via Zoom are invited to submit questions throughout this program by using the Zoom Q&A function. Please type in your questions, your comments, suggestions, ideas throughout, and we'll feature as many as possible after the presentation in the program. We'll try to end the formal program by around 6:30 p.m. It is now my pleasure to ask HMA President Dr. Elizabeth Ignacio to welcome all of you, and then we'll have the introduction of our special speaker.
Aloha and good evening to our online audience and to here at HMA. I'm so grateful that we can all come here together. As you guys know, prior authorization has continued to be such a horrible delaying process for our patients and ability for physicians to deliver good, high quality, safe care. We've got to work on these solutions together. And I'm so pleased that we have all these stakeholders and interest groups that can come together and bring knowledge from the mainland, from Dr. Rosenbloom specifically this evening, and we can all discuss it and come up with solutions together. So I'm grateful to welcome to the podium our colleague, Dr. Kaohimanu Akiona-Dang, who is part of the Hawaii Physician Crisis Task Force and one of our stakeholders that we've worked with many times in terms of a lot of our legislative work, and especially recently on the GET, but also in other efforts to educate the community about the physician shortage and other regulatory challenges for physicians and our patients. So without further, I'll have Dr. Akiona. Thank you.
Aloha uwinala, and we're kind of creeping into ahi, so kind of getting into that nice dinner time hour. Thank you for joining us, and hello to the people in the room, and hello to the people out there. As you know, I'm Kaohimanu Akiona, a physician on the Big Island and Molokai, and probably a lot of you guys have gotten some emails, and we've been talking about a lot of the hot topics that kind of are weighing on us lately. And prior authorization, I think, is one of the fun proxies for the challenges that we're facing in the state and in the nation. And it was really, I'm really fortunate enough to have a friend now that I get to introduce to help us with this conversation. I think that conversation leads to education, and education is probably one of the biggest things that all of us physicians, no matter what specialty you're in, it's kind of one of the bigger kuleana that we have to ourselves and then to our community and to our patients. So it's my honor to present Dr. David Rosenbloom. Dr. David Rosenbloom is currently a professor of public health at Boston University, where he focuses on U.S. and international health policy and issues relating to substance use disorders. His more than 40-year career spans the public, private, not-for-profit, and academic health sectors. From 1975 to 1983, as Commissioner of Health and Hospitals for the City of Boston, he was the city's public health officer and CEO of the city's public delivery system, including Boston City Hospital, 22 neighborhood health centers, and the emergency medical system. From 84 to 88, Dr. Rosenbloom was vice president and then president of Health Data Institute, a company that pioneered the clinical analysis of medical claims data and developed managed care tools and techniques used throughout the country today. He has conducted and published research and led national community-based demonstration projects in addiction prevention, treatment, and policy. He's also led development of web and mobile-based interventions to help individuals quit smoking, assessing the risk for alcohol and drug-related health problems, and reduce unhealthy drinking among veterans returning from combat. Trained in poli-sci, MIT PhD 1970, he conducted some of the first research on the development of the professional campaign management industry in the US. He was the founder and director of Join Together, a program of Boston U School of Public Health to assist communities throughout the country as they develop leadership and effective strategies to address addiction and gun violence programs. He served as a member of the National Advisory Council for NIDA from 1999 to 2003, and was the director of the Spalding Rehabilitation Hospital from 1984 to 2013, chairing this board from 2006 to 2009. Additionally, he's co-founded and chaired the Community Medical Alliance, which is an HMO for people with catastrophic medical conditions. He is also chairman of quitnet.com from 2000 to 2005 and has served as a director of Stop Handgun Violence since 1995. In 2015, he helped found and serves as a director of the Police Assisted Addiction Recovery Initiative, and he's currently on the chair for Boston Foundation for Sight. He joins us from Boston. We've given him a couple of days to kind of warm up from the weather, and it's my honor to introduce Dr. David Rosenbloom today.
Thank you very, very much. It is a pleasure for my wife Alice Richmond and myself to be here today, particularly since we left 40-degree weather in Boston to come here. So we're just delighted to be here. And I want to thank the folks who have worked so hard to make this possible, Dr. Dan Gacchiono, Dr. Grostritz, David Assay, Lisa Rance from the Task Force on Provider Shortages, and Dr. Kevin Withy from the medical school, and the Dr. Ignacio and Mark Alexander from the Medical Society and the Medical Association. I'm glad everybody has actually come together tonight, and I hope that coming together actually continues as you work on this really very, very difficult problem together. So tonight, in the next few minutes, I'm going to start with a confession. It's usually a good thing to start with confessions. I'm going to provide a definition. We'll talk a little bit about the context for prior authorization here in Hawaii, because everything is local. Tip O'Neill used to say, all politics is local. And so we have to be concerned about the local context. I'll say a bit about the pros and cons of the case for and against prior authorization. I'll give you my general recommendation and then concede that that's not going to happen. I'll talk a little bit about what's going on in some of the other states and close with some suggestions of my own for your process here in Hawaii, which you will, of course, be free to ignore. But I do want to get into dialogue with those of you who are in the room and those of you who are online tonight. This is the start of 4 days. Tomorrow, we're going to have another live panel session here in Oahu. We're going to move to Hilo on Thursday, Maui on Friday. So I hope we'll have a broad discussion of the issues that we're working on together. So my confession, as Mark said in his introduction, I happen to have been in the room where it happened at the Health Data Institute. The Health Data Institute created the capacity to merge claims data and hospital data to create a surrogate of the medical record. In those days, all medical records were paper. There was no capacity to actually understand what happened to the patient. And so we created this surrogate of the medical record. And when we did and could analyze it, we began to see huge anomalies. We saw great variations in care. We saw great variations in price. And at the same time, our clients, the major health insurance companies and the biggest employers in the country, they were beginning to say, what can we do about rising costs? And the insurance companies, almost as a marketing, wanted to be able to tell their clients that they were doing something about the high cost of care. And so we began to create these managed care tools. It was called prior certification in those days, large case management. In those days, a large case was anything over $50,000. That's an emergency room visit now. In those days, the large case management was $50,000 above, and focusing on second opinions. The philosophy, however, was this was a discussion and a negotiation. It was not refusing care. The philosophy was to defer to the physicians. And frankly, I put this slide up to say that this was actually recognized when the Institute of Medicine did a review of all of these early programs. I'm pleased to say I came across this recently. I'm pleased to say that it actually documented that our approach was negotiation and not refusal. In fact, I don't remember refusing. So what we mean by prior authorization, as healthcare.gov defined it, it's approval from a health plan before you can get care or a prescription filled. It's getting permission from father who knows best what to do. Now, let me say a bit about the Hawaii context. And you know much more about than I. I just found a couple of items. A severe physician and other provider shortages in various parts of Hawaii. An insurance monopsony, if not monopoly, of one major carrier dominating the health scene here in Hawaii. A very high use of prior authorization in the medical care system with very low levels of appeals to initial decisions. And while Hawaii, from the rest of the country, looks like having the best population health in the country, you all know very well that inside Hawaii, there are very wide variations in population health, as there are, by the way, in very many cities. In Boston, the average life expectancy varies by 20 years by neighborhood in Boston. And so you have these same kinds of variations here in Hawaii. And in the context of Hawaii, you always have to be concerned about what I call the health ecosystem. The entire environment in which health either does or does not get expanded, healthcare does or doesn't get provided equitably through the society. And the healthcare ecosystem, to be a healthy healthcare ecosystem, you've got to have financially stable public and private payers. You've got to have employers and patients costs that are affordable so that we eliminate medical bankruptcy. The pay and conditions of work have to be attractive enough for the providers to come back the next shift. In healthcare, as many other fields, your assets walk out the door at the end of every shift. And you've got to do enough to bring them back the next day. And so a healthy ecosystem actually is concerned with all of these conditions that make it possible for the providers to stick around. Hospitals, of course, have to get enough money to stay open, maintain their plant, equipment, and personnel. And patients have to have access and confidence. All of these things have to come together in some balance for a healthy ecosystem. And it's in that context that I think we want to look at prior authorization and see what role prior authorization does or doesn't play in that context. So let me turn to what I think some of the facts about prior authorization. I think insurance companies want prior authorization. And I think they want it on the upside to prevent unnecessary and harmful care. They want to be able to encourage cheaper alternatives that may achieve the same clinical results. And they also want to reduce spending on poor medical care if they can. in particular, I think, and I think there's some reasonable evidence for this, I think that prior authorization is central to the insurance model, particularly in Medicare Advantage. So I think that for the insurance companies, whether it's good for them in the long run or not, I think particularly in Medicare Advantage, insurance companies' profitability at the moment is largely associated with prior authorization. For the insurance companies, particularly in Medicare Advantage, and more than half of the people in Hawaii who are 65 or older are in a Medicare Advantage program, prior authorization helps them reduce current spending. And I want to focus on the word current, because for an insurer, current means right now, this quarter, this year, all of their planning is what they're spending this year. And by the way, hospitals are the same way. You know, I used to teach my students that in hospital revenue 101, you got to bring in all the money you can today because you don't know what the bastards are going to do to you tomorrow. And so the insurance companies work the same way. We've got to minimize what we're spending today because we don't know what we're going to be tomorrow. So it reduces current spending, they think. It frees up cash in Medicare Advantage for them to provide other benefits, lower people's premiums, give some dental care. It enables the Medicare Advantage plans to bid low the next time they have to reprice their premiums, the next time they have to compete to be able to offer their plan in a particular geographic area. And so if prior authorization lowers their current expenditures at all, it strengthens their ability to bid below the expected payment for Medicare patients. This is all sort of in the woods, technically in the woods, maybe the weeds. But what I'm saying is that prior authorization in the Medicare Advantage program is one of the tools that enables the Medicare Advantage programs to bid below the Medicare expectation. And when they do that, the government says, well, you're going to be so efficient, we're going to reward you with rebates. And those rebates, tribute to profit, can be used to help expand benefits to members. And that becomes it's a self-cycling thing. And another thing it does, and this is a little bit cynical, it reduces provider productivity. Tying providers up in prior authorization reduces their productivity and thus their billing insurance. And so I think that those are the elements why it has become so important for the insurance companies at the moment. Now, every time I think about this, every time I talk about it, one dominant fact comes to mind. There is no prior authorization in traditional Medicare. I have traditional Medicare. I can go any place that accepts Medicare. My doctors do not have to get permission to do tests that they believe are appropriate. But with all of that, traditional Medicare is cheaper for the federal government than Medicare Advantage with prior approval for almost everybody who does. In fact, the MedPAC report to Congress in 2023 said that Medicare Advantage plans, on average, get 6% more per individual than the federal government would have spent for that individual in traditional Medicare. And that added up to about $27 billion in 2023. And as Everett Dirksen, the former minority leader in the Senate, used to say, $1 billion here, $1 billion there. Before long, it adds up to real money. And so I think, so that's why I think the insurance companies really like it. However, I don't think prior authorization actually works. I don't think it works for the providers, and I think over the long haul, if there is a long haul, it doesn't work for the carriers either. And these are the reasons that I'm going to be talking about for the next few minutes. There's very little evidence prior authorization is actually efficacious. It doesn't save them any money for the health system. And as a health policy guy, I like to think about the health system, not just healthcare expenses as part of it. There's no consistency among the carriers. I'll get into that in a minute. It clearly contributes to provider burnout. If it didn't, none of you would be here. And so it harms patients. And artificial intelligence adaptations are likely to make prior authorization work less even than it does now. So let me start with the research. This is a very wordy slide. The bottom line of this last comprehensive review of all the studies about specific elements of prior authorization, they all wind up saying the same thing. And what they say is, we cannot draw a conclusion that prior authorization is. This particular conclusion says there's some evidence that it reduces utilization in some areas, but that is often offset by increased utilization in either the same or other areas. There's some evidence that it saves carriers a little bit of money, but on the other hand, there's evidence that it doesn't. And so all of the conclusions, all the published research says, we don't know. We don't have any evidence to say that prior authorization is effective over time. Now, prior authorization does cost a lot of money. This is a 2020 report from the Brookings Institution, which outlined the administrative costs for providers, hospitals, insurance companies, and by the way, for the government. The red, the darker color here, it's kind of small, I apologize. The darker color said that hospitals in 2020 spent $101 billion on claims payment and managing prior authorizations. Physicians' offices spent $94 billion on claims and prior authorization. And the payers, the insurance companies, spent $104 billion in 2020 on bill management and prior authorization. Governments spent $52 billion on everything. So governments still remain quite a bit more efficient in their processing of healthcare than the private sector does. And by the way, these costs are 4 or 5 times what is spent in any other country as universal health. So we spend a lot of money on prior authorization. And one of the reasons we're spending a lot of money is that it has spread geographically and in intensity in a major way throughout the United States. These 4 maps show the spread of inpatient acute hospital services. In other words, prior authorization to going into the hospital. Top left, sort of around the country with different intensities in 2009. Right hand, much darker blue, many, many more states and counties. So it's spread both geographically and intensity. These are just 2 examples, inpatient hospital care and psychiatric hospital care. So it's spread dramatically between 2009 and 2019. What's actually going on this year, we don't know, because there is change, there is ferment, but it really has spread. So when doctors think there's more of it, there really is. Now, consistency? No. It seems to me that if something is medically necessary, it is or it isn't. But in fact, there's no consistency across the country among the carriers. These 2 graphs, the bar graph shows the major carriers, and the frequency in which a patient in a Medicare Advantage plan could expect to experience prior authorization in a year. And so you see that Humana, all the way up on the left, members of Humana plans in 2023 could expect to experience on average 3 requests for prior authorization for the care that they were getting. And all the way down to Kaiser Permanente, their Medicare Advantage folks could expect less than 1 prior authorization request a year. Now, the other graph shows the rates of denial by the insurance companies. And so Centene, which is the 3rd most frequent requiring prior authorization, it had the most frequent denials. So it asked a lot and denied a lot. Humana, down toward the right, asked a little bit, only 1 on average a year, but United turned down 9%. Okay, so you've got 2 things going on here, both inconsistent. The refusals, the requests, either something's medically necessary or it isn't. So this kind of lack of consistency is, I think, one of the things it's worrisome. Let's take a look at cost. And I want to look at cost in 2 ways. One, anecdotally, what do doctors experience? And this information came from the American Medical Association's 2024 survey of physicians around the country. And they basically said that more than 80% of them thought that overall utilization always or sometimes or usually increased after prior authorization. More than 80% of them said that out-of-pocket costs for their patients sometimes increased. And how did these things happen? Well, 3/4 of the docs said because there was ineffective step therapy that we had to apply before we could get approved. 3/4 of them said it got more expensive because extra office visits. Or that unnecessary, half of them said unnecessary emergency room visits. 1/3 of them thought that there were unnecessary hospitalizations as a result of prior authorization. And prior authorization in the employed market, more than half the docs thought that because of delays in care from prior authorization, their patients were less effective in work, less productive in work, and more likely to miss work because of illnesses that could have been controlled. And similarly, prior authorization, the docs, and you all who are docs know this better than I, on average, docs get about 39 requests a week. They spend up to 13 hours a week doing prior authorization. And 89% of them said that they are burned out in part because of prior authorization. And only 20% of docs said that they actually participate in appeals of turndowns. And so a turndown is effective, even though everyone's got the right to appeal. In fact, there's very, very little going on around the country. And in Hawaii, I think I read someplace that patients have to put in a $15 refundable fee to get an external prior review. So that's the problem for many patients. The second way to look at prior authorization is that it doesn't reduce total spending. This simple formula is one of my favorite tools for understanding health. Total spending equals the number of units of care that we provide times the price we pay for each of those units. if you want to control total spending, and by the way, I don't know whether anybody really wants to control total spending. Docs want more, hospitals want more, I want more care. And so I don't know where the constituency for total spending is, but if you're going to control total spending, you've got to control both utilization and price. Because if you control only one, you're going to get you the other. And that is exactly what has happened for the last 50 years here in the United States. And by the way, it's not utilization so much. In the United States, the driving force in total healthcare cost is price. It's about 3/4 of total increased spending is due to price, not utilization. So that's why I think the notion that prior authorization is a key element in controlling price is probably not likely to be true. Prior authorization does harm. It's not neutral. And the docs in the survey in 2024, looking at the impact on clinical outcomes, at least 1/3 said that prior authorization was rarely based on evidence. So folks are being denied or delayed care in ways that do not reflect evidence-based care. More than 1/4 of the physicians in the survey said that prior authorization had led to a patient's hospitalization. The delay led to hospitalization. 18 of them said that they had a life-threatening emergency as a result of a prior authorization denial or delay. And 8% of them said that prior authorization had permanently damaged their patient's health or led to premature death. That's a serious indictment of harm. How does this work? One group of physicians took a serious look at what happened to their patients in the use of a new medication effective in cardiac care. And they found 5 things that happened. Prior authorization required extensive and different documentation than other medicines. Required that they give them hard to get data, such as detailed data on adherence to prescriptions that they didn't have access to. That prior authorization was limited to prescription by specialists only. And in many places, there were no specialists available, or they were going to cost the patient a lot of money, or they were required to do multiple step therapy, many steps to try, all of which cost money. Prior authorization denials are particularly severe in Medicare Advantage in requests for post-acute care, home care, or nursing home. This was a study released by the Senate Permanent Investigation Subcommittee last year, looking at denials of post-acute care by 3 of the major insurance companies. Several things are evident. One, the denials have gone up sharply, particularly for United Healthcare between 2019 and 2022. And the rate of denial for post-acute care is dramatically higher for all of the carriers than their rates of denial for regular care. And I mention this because post-acute care is where there's a lot of money. And so a few denials in post-acute care can equal lots of approvals for stuff that's very cheap. The Medicare PAC, the advisory committee, did a study of what happens when people leave Medicare Advantage to go back to traditional Medicare, and about 10% do every year. they wind up using a disproportionate amount of post-acute care. So they've been denied post-acute care in the Medicare Advantage program, leave and go get it in traditional Medicare. So on balance, said the authors of this review, on balance, the cost benefit shifts sharply away from prior authorization. You get to spend less time with your patients. There's social injustices involved, costs money, and it burns out professionals. And so on balance, it probably should be done away. So here's my proposal. My proposal, as I said in the Boston Globe op-ed, which led to my coming out here, for which I'm grateful. You never know whether anybody reads these things. Not only did it read, I got to come here. So my proposal was to do away with prior authorization. And let's see what happens. In a very serious way, not just to sort of do away with it, but let's study what happens to total cost in a state or a region. What happens to total utilization? Does it go up as predicted? Does it increase total costs if it goes up because it may be balanced? What happens to patient outcomes? What happens to physicians' income and burnout? What happens to carrier profits? Because in a healthy ecosystem, we need to sustain carrier. And does it do anything about system complexity, which is one of the great enemies of our U.S. healthcare system? Well, it's not going to happen. And so what can or should be done with prior authorization, at least in the near term? Let me just turn quickly to what's going on with carriers, the federal reforms, and some state reforms. Carriers are reacting to the pressures that have been put on them with prior authorization. And so they are reducing the volume of items required prior authorization. United announced recently that it was doing away with 20% of its prior authorization. Cigna has eliminated 25% of theirs on medical care. They are speeding up and simplifying reviews. That may or may not be a good thing. They are rushing to automate using AI. The Senate committee, the investigation committee, found that United's rate of denials for post-acute care more than doubled within the year after they put in an AI-based review system for prior authorization. Many of the carriers are creating green cards, free get-out-of-jail cards for providers who have very high compliance rates. So that's what the carriers are doing. The AMA survey says that it hasn't seen any evidence that they've really changed their tune, but the providers are saying that they're reacting. The new federal rule, the federal government published a change in its process for prior authorization in 2024. The rules will take place in effect in 26 and 27. There'll be uniform, what they call APIs. I'll talk about that in a minute. For patients, providers, and payers, there'll be a response time limits for 72 hours for urgent care, 7 days. Denial reasons will have to be communicated, and some metrics will have to be reported on what they're doing. And the feds also issued new guidelines on standards that plans have to use, that you can't retroactively take something away after you've given it. You've got to keep things alive if somebody changes plans. So they're trying by process to make the whole process smoother. But this has nothing to do with the substance. Every carrier can continue to have its own criteria and under the federal rules. So I think, and this is important for folks who are going to build on the federal rule, I think that the federal rule has this idealized version of what will happen. That the treating physician will sit at his terminal and enter a proposed diagnosis or treatment into the screen. Screen will appear and say, this patient's carrier does require prior authorization for this. This patient's carrier does not. If the patient's carrier says there's got to be prior authorization, then the next screen will magically appear with the criteria for that carrier. And that'll be auto-filled by the EHR, but the doctor needs to supply information. Well, then decision will be made in real time. Denials and deferrals will go to whatever the individual carrier is processing. I don't know how many of you can actually do this in your offices. I don't know how many electronic health records can actually accommodate this. One survey suggested that no more than 20% of the docs could actually do this. So in considering how to do prior authorization in the future, this is what the federal rule hopes everybody will be able to do. Whether they will or not, it's not exactly clear. Now, all of this assumes there's going to be a lot of AI involved. And I think that some of the states are now beginning to pass laws limiting the use of AI as a decision tool for prior authorization. As I said a moment ago, the Senate found that when AI was introduced to these review processes, denials went up. And that may very well be a harbinger of things to come. So let's turn to what other states are doing. The American Medical Association has really been taking a lead on this, and they publish every year a summary of all of the states. And I quite arbitrarily picked the state page that's got Hawaii in it for 2024. And so you'll see that there's a lot of room for new policy in Hawaii. Virtually everything is blank at the moment. Idaho has policies in a couple of these areas. Illinois looks like it's got policies in most of these areas. And I put this on the board because it outlines the policy areas that will need to be considered as you go into prior authorization reform. What's the question set? What questions are being asked? What's the response time? How long does the prior authorization last? Can there be retrospective denials? Can you have prior authorization and still not get paid for the service? What are the clinical criteria? What happens to change the rules? Is there transparency? What are the qualifications of the reviewers? Are any services left out? And is there a peer-to-peer system? So those are the policy areas that you'll be considering in prior authorization. And this just shows what some of the states around the country are doing to do all of this. Some new ideas that haven't been put into law yet. The bill that's pending in Massachusetts would assign prior authorization to an independent commission. The independent commission would run all the prior authorizations for all the carriers in the state using one set of clinical criteria. In the view of the chairman of the committee in Massachusetts legislature, the insurance companies have too much of a vested interest in the outcomes. She wants to have an independent commission do it. Some notion about a single set of required prior authorization. Do away with the inconsistencies. Some proposals have carriers being required to pay doctors if the doctors are going to have to provide significant information in time to a prior authorization. In other proposals now being considered, the carriers approve a high percentage of their appeals. So it's denied now, approved on appeal. If the carriers have a very high level of approvals upon, after denial, then this idea says they probably shouldn't have had prior authorization to begin with. And so if they continue having this great mismatch, we're going to fine them. Not in law yet. And another one, set a glide path toward eliminating prior authorization. See what prior authorizations are on an annual basis and systematically reduce the level or importance of them over time. Ultimately, perhaps having it go away. So those are some of the ideas that are now being considered. I have a simple advice to those of you who are going to be working on this problem in Hawaii. Start with a simple question. What problem are we trying to solve? Don't start with the question, how are we going to fix prior approval? Because one of the things that I have found in the years that I've been doing this kind of stuff is that people can sit around the same table and have very different notions in their head about the problem they're trying to solve. And so trying to surface this at the beginning, we've got to have a balanced outcome. We're going to have an outcome of some kind, but we'll get there faster and probably more effectively if we surface what problem we're trying to solve and what order we're trying to solve as a starting. To make recommendations that are going to stick in Hawaii, I think your working group is going to need great detail on what actually happens now, well beyond the anecdote that we live with most of what we do in our lives. It should be able to learn what happens to patients with denials. What are the consequences in the system now? Do our providers, our insurers, our doctors, our hospitals have the capacity to do things in a different way? How important is prior authorization to the insurance companies here in Hawaii? We really need to understand that. And what do patients, employers, unions think should happen in this area? So that's what I think you're going to need. I really thank you very, very much for having me out here. And now I turn to what I really came to do is learn, listen, and help engage in conversation tonight, tomorrow at the medical school, Thursday in Hilo, Friday and now. Thank you very, very much. Questions, comments, attacks? Thank you.
Thank you very much. Thank you very much, Professor Rosenbloom. Now is our time to begin with a Q&A. We're going to switch to a more conversational format over here. We ask that people who are on Zoom, please submit their questions via the Q&A function that you have on Zoom, and then we'll be able to offer those to Dr. Rosenbloom. Assisting with the questioning and monitoring things in here and guiding us will be Dr. Kelly Withy, again from AHAC and JAPSA. Thank you very much, Dr. Rosenbloom.
That was a wonderful. I like you're giving us the information we need about other states and what they're doing and ideas for us. Kind of at the beginning of the pathway, and I know Representative Martin, who's on the line, I saw introduce legislation this year that would allow us to collect data from all the insurers and have a group that reviews statistics. So that's exciting. The first question, though, is by somebody who loves the talk and wants to know if we can all get a copy of the slide.
Oh, sure.
Okay,
Absolutely.
good.
In fact, some of the detail on the slides is there precisely so that they'll be useful.
Perfect, because that is very helpful for all of us, because you've done a wonderful job of reviewing the information. I wanted to know, since it looks like our legislation is hopefully going to pass, what are the particular data points we need to get from all the insurers to make sure that we're monitoring things?
Well, ironically, I think you need the very information that other states are now requiring people to report. So I think in order to come up with a balanced policy, you're going to need real reporting by diagnosis and by category, the number of prior authorizations by detail. The approval, percent of approvals, percent of denials, what happens after a denial and an appeal. So I think all of that and the time involved, how long does it take to get something done? So all of that, which is now being reported, and if you look at the requirements for some of the other states, and what they're required to report is probably what you need now in order to come up with really good Hawaii-specific rules.
Which states?
Uh,
It's okay.
Michigan, Illinois, California, New York. They're luckily the AMA publishes this every year, and that chart will lead you. And the new federal law, the new federal policy outlines what carriers have to report in the federal programs.
Excellent. Do you think what Massachusetts is doing is a wise idea to have I'm assuming it's an independent group, review all insurances prior auth and make decisions?
If we're going to have prior authorization at all, then I think it's probably best handled by some neutral entity. So the feeling in Massachusetts, and by the way, the Senate chair, with whom I happened to have a session with recently, smiled and said, I don't know whether this is going to happen. So, we're not sure it's actually going to happen. But she feels strongly that the insurance carriers have too much of a dog in the fight to be neutral. And so whether it happens or not, I don't know.
We'll look at Massachusetts and see what they do.
Do you have any other specifics in terms of who would be in that commission? Like who has input? I'm just curious, like, have they talked about who would be serving on that kind of?
Yes, and like most things, it's all the vested interests get, all the stakeholders get seats at the table, and consumers are represented at the table as well. The problem with that approach, and it's the very common approach, the problem with that approach is that if you come to the table to defend your turf, it's very hard to get stuff done. And so, and you say, oh, I'm parking my interest at the door. Well, that's hard to do. But the answer to your question is, yeah, every stakeholder would be represented on this rulemaking commission.
David, I think that we have to, for us, there's sort of a political reality that I had decided at the beginning. How much would this legislature be willing to go? And in seeing that, what I see was we had to take at least one step. So the reporting part is actually not very controversial because they're already doing it, federal government. So, it's not particular. And there's actually a reporting process for the state Medicaid agency that none of us even knows about. It's not published. And kind of curious about why it is published, for whatever reason. On the other hand, if the working group idea that we proposed fails, like it very likely will, for all kinds of reasons, then we have to come back and say, hello, So that's kind of where we're at. It'd be close to, pinch ourselves and think it's a miracle if we took this working group actually came to a place to say, we'll come to consensus. But, I think from the point of view of the leaders of our legislature, that's the requirement.
And that's true in many other legislatures as well.
Yeah.
And I think it's probably the only starting point that will reasonably pass most legislatures. And if you start with transparency of information, that information can be powerful.
Yes.
in motivating consensus. There may be surprises to the current defenders of prior authorization in the data. And so I think that's a very practical place to start.
I want to leave room for other questions. I just want to say that there's one other kind of reporting that I will insist that we embark upon. It's not in the legislation. It's simply to ask the physicians and healthcare clinicians in the state to report also when they believe something is harmful is happening to their patient. And I think again, that collection, that material can be, I think we have to mandate that. We just have a place for that to happen. But I think that could be very valuable as well as a check and balance.
Go ahead, Nadine. I just wanted to monitor very areas for us that are cover
the case, something along the lines of lawyers and cease and desist, and a little bit of bullying of the clinician. It's a very precarious place for us to ask our physicians to single themselves out.
Well,
True, but it's hard to without the case.
Well, I think even if we though just had a reporting of an incident from the physician's point of view, and that person's name will never be released, although I'm going to need the name to be able to go back to look at what happened. But I think there's some value to that. I mean, you all know that my secretary died after multiple requests were made for a continuous glucose monitor. She's dead. And it got approved, but she was already gone.
Adverse event reporting is a standard practice in many health departments. And so there's a way to require reporting as well that protects folks. So I think that there's great controversy, but there should clearly be room in the system for adverse events to surface.
We have a question about black carding. Instead of gold carding those who are good, should we black card those who, let me read it out, ID providers who improperly utilize certain procedures and meds? What are your thoughts?
Shaming has a great tradition. I think that the practice of medicine has always been strengthened by peer review, and part of the problem of solo practice and individual practice is that is often missing. And so I think that, quality does require communication. And the black carding would necessarily grow from claims data, not necessarily any additional information, just as gold carding flows from the claims data and the approval rate. So I think issues of how we ensure quality, continuing debates, whether black carding on prior authorization is an approach, I honestly don't have a view.
Do you have a sense about what the criteria would be for gold carding?
Yeah, it's a very high approval rate.
90%?
Yeah, some of them are in the 90s. Yeah, so that if most of what you submit gets approved, the vast majority of what you submit gets approved, well,
Then you're good.
you're good.
But you don't think there's a set number? It's not like 90, 92?
There's
because-
no consistency in any of this. That's part of the problem.
All right, let's see. Prior approval is clearly practicing medicine itself. Is anyone looking at holding physicians who allow themselves to be used by insurance companies responsible, or hold the insurance company liable for bad outcomes on denied cases?
there's a big debate about whether it's practicing medicine. If you look at the traditional definition of the practice of medicine, which includes often the words of advise, then a prior authorization which advises on whether or not care should be paid. And the distinction, oh, we're not telling you not to do it, we're just not going to pay. That is a distinction without a difference. Because very little medical care can be paid, can be afforded if there's no payment. So to say that they're denying payment but not care is self-serving. So so is it practicing medicine? A doc who is a utilization review doc, prior authorization doc in Arizona, made a decision to deny surgery. The surgery took place and it became crystal clear that it had been medically necessary. The Board of Medicine in Arizona issued a rebuke to the doc, saying that the doc had made an error and that he should be careful in the future about not making any more errors. The insurance company sued the medical board, saying the medical board had no authority over this medical review officer because the medical review officer was not practicing medicine. And therefore they had no jurisdiction. The court in Arizona, highest court in Arizona, that heard this case, said that's nonsense. This is absolutely inextricably interwoven with the practice of medicine. The board is authorized to supervise this doc. That's one of the few cases where it's actually been tried. HMOs started out being immune from prosecution, making the claim that they were not practicing medicine. My wife, who's with me today, was a trial lawyer. She brought one of the first cases against an HMO to try to hold it liable for having denied care to a patient who then died. That is now more or less settled law in some states, where carriers can be held liable for decisions that affect patients, that hurt patients. Still very much law in progress. Are they practicing medicine? I think it depends on the definition of the practice of medicine in state law. And I think there's some cases in Hawaii where this question of who's practicing law now is being worked on. And your legislature has a definition of practice of medicine that may, Navra, thank you, practice of medicine that may actually cover prior authorization. I don't think it's contested.
All right. Thank you, Dr. Rosenbloom. There wasn't anything you said that I disagree with. I'm CMO at a 501c4, 70,000 member local, not publicly traded, primarily Medicaid health plan with a small DSNP Medi program founded by Community Health Center. We have a very low denial rate. I will be taking back your suggestions to my health plan and our state's Medicaid program.
Thank you very much. I have great fondness in my heart for community medical centers. They are the heart of the delivery system in Boston. And they are essential to population health.
Okay, so here's a combined question. Are there any areas that do not require PA, do you think? Or,
Yeah, traditional Medicare. I mean, you have this great natural experiment going on every day, all over the country. People in traditional Medicare, people in Medicare Advantage. They're all more or less the same age. There is selection of who belongs to Medicare Advantage and who belongs to traditional Medicare. Traditionally, a healthier subset of the population is in Medicare Advantage than traditional Medicare. But the reality is For years now, Medicare Advantage has cost the federal government more than the same patients would be taken care of in traditional Medicare. So yeah, traditional Medicare doesn't have prior authorization, and it's cheaper for the government and has been for many years.
Ironically, yes. Oh, are there any states that have banned prior authorization completely? I don't think there.
No, but I live in
And then what will happen if PA is totally removed?
I don't think we know.
Uh,
I think that, and it depends on how long the time frame you want to look at. Okay. My guess is utilization would go up in certain areas. Cost might or might not go up. Patient outcomes might get better if we eliminated it. And over time, I think cost would level out because you would, over time, avoid some of the costs now incurred by utilization delays. I mean, smoking cessation. Lots of insurance companies like to deny coverage for smoking cessation. Right? Well, it doesn't work very often. Got a lot of high relapse rates. Blah 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 blah. Well, you don't have to have very many successes to avoid a subsequent cardiac or lung event. Now, it's not in this year. So the insurance company doesn't care in a certain sense because it's this year's money that they're worrying about, but maybe future utilization. So I think over time, my guess is that the cost even out.
I know one area it would impact that would be burnout. Burnout would definitely.
Well, that goes back to the ecosystem in which care is delivered. And by the way, part of the physician shortage might be alleviated if doctors had between 4 and 10 extra visits a week that they no longer have to devote to prior authorization. So physician productivity might go up, access might go up. So that might happen in the short term.
Wouldn't it be nice if we were the first state to be prior auth free? Anyway, Nadine.
So much for everything you said. I think in the end, prior authorization per your presentation has been about reducing procedures, guiding our clinical teams to maintain standards of care, and ultimately lower unnecessary cost. But the reality is this has turned into a bigger quagmire than I think we all had planned over the years. Some of our local providers are, not providers, excuse me, payers are telling us that only about 10% of the prior authorizations that go through the machine actually end up standing. That gives you more to 80 to 90% of prior authorizations did not need to go through. So only 10% were denied is my point. So that means 90% went through an entire machine on both ends, the provider end of having to do it, as well as on the payer end and whoever they contracted to go through the process of eventually approving it. Do you know anywhere in the United States, or do you have any models that basically flip the entire conversation? Why don't we, the providers, as well as the payers, just focus on the 10%? Let's go back to the original again, reducing the unnecessary procedures, keeping our eye on the total cost, but we have enough data to, Dr. Lewin's point, to guide us to what are the procedures and the highest cost items that we should focus on, and basically begin there.
I think that's exactly correct. I think it's exactly correct on several levels. If they eliminate the ones with very, very high approval rates, but we don't have transparency at the moment as to what those are. So we need that transparency. And in fact, until very recently, nobody was required to do it by category of care or by ICD-9 code or any way in which we could begin to focus. I mean, the great irony of all of this is that when we started this at the Health Data Institute long ago, there were relatively high levels of unnecessary and low value care that we sought to help reduce. 40 some odd years later, billions and billions and billions now being spent on prior authorization. We are saying the same thing, that there are high levels of low value care that we ought to focus on. We are not doing it. We may have the data if we choose to look at the data and analyze it. One of the reasons I suggested that glide path idea, that maybe over a period of time, we take every year what's going on and focus our attention down. But in order to do that, we need transparency.
So I think the answer to this question is no, but is there a way for Medicare Advantage to remove the PA requirements, or does this require federal
It
legislation?
certainly does not require federal legislation. In fact, what the federal requirement is, don't you guys dare to use your prior authorization to deny anything that would be covered in the traditional program.
Oh,
So,
but they are. All the time.
well, that's exactly correct. That's where transparency may be helpful. So there's no requirement for prior authorization in federal legislation.
And it's not banned. But you can't treat anybody worse than regular Medicare.
That's the law. That's the regulation. We had a question.
Oh,
Thank you. I understand there are comparative studies examining utilization patterns, physicians and advanced practice providers that suggest that APPs can achieve similar or better outcomes on quality metrics and utilization. But in attending a radiology conference in Boston in August, I learned that a lot of advanced practice folks are allegedly they're needlessly ordering a lot of advanced imaging studies, and that's contributing to utilization rates in radiology, contributing to the problems that they're experiencing for shortage. Do you have comments on that? How can we?
Well, I do have a comment, but it's not necessarily related to just people in advanced practice. Medicine operates in high levels of uncertainty. And when we have uncertainty, we like to throw another test to try to help us resolve that uncertainty. And so I think there are lots of practitioners at all levels who want to order a test to resolve their uncertainty. And I'm not exactly sure what we do about that, but it was certainly true when I was running a health system that residents ordered a lot more tests than the chiefs did or the attendants did. So I think that that finding is not surprising, but I think we would find the same thing true if we looked at a lot of other subsets.
okay, I'm getting the wrap it up signal. We have 2 outstanding questions, but how about if we, maybe we can screenshot and give them to him and maybe let the group know that was on the phone, the answers to those perhaps? Thank you so much. This was very enlightening.
My great pleasure. Thank you for having me.
We just want to take another opportunity to thank Professor Rosenbloom for sharing his great knowledge and engaging in so many questions. As Dr. Withy said, we'll try to collect whatever questions that are outstanding and get back to people. Also, again, to reiterate, PowerPoint will be made available and the entire presentation and conversation will be available on the HMA YouTube in a week or so.
Great, and I guess, and tomorrow night at 5:30, we're going to have another live and Zoom discussion.
Right, 6:30
A little
tomorrow.
later, so the
6:30.
doctors can
6:30.
get there.
Right.
6:30 tomorrow at
At the medical school auditorium.
And also on Zoom. And we'll also, again, make whatever PowerPoints are available. If the presenters are okay with that available, and we'll have the recording available to the community as well. That's great.
Wonderful.
Thank
Thank
you
you.
both very much, and thank you to all of you for making time this evening.
Thank you.